right. Hello, welcome everyone. So we can get started. I'm Kelsey Johnson. I'm the program manager here with MapNet. So thank you for joining our call today on Catatonia with Dr. Joellen Wilson. So I will hand it off to Dr. Keshvan to do an introduction.
Hi, good morning, everyone. It's my incredible pleasure to introduce today's speaker, Dr. Wilson, who is a psychiatrist, epidemiologist, and a physician scientist at the Veterans Administration Medical Center in Vanderbilt. Um, I came to know Dr. Wilson through a patient of mine. She said, we've been working with her son who has had catatonia, and she said, I have been in touch with this nationally well-known psychiatrist who knows a lot about catatonia. Would you connect me to, or would you talk to her and you get some input on how to take care of my son? That's when I came across Dr. Wilson. She was kind enough not only to give us advice on that patient, but also she agreed to teach us on catatonia, an increasingly well recognized syndrome in psychosis, which we used to see a lot in the days when I did my training, like 30 plus years ago, but has become much more well recognized in recent times. Dr. Will her research is in the area of acute and chronic forms of brain dysfunction, across a number of disorders, including mental illness and aging. Dr. Wilson completed her medical school and psychiatry training and the consultation liaison fellowship in Vanderbilt. And then she joined as faculty in 2014. And her research has focused on catatonia and coma in the context of critical illness and prospective. And there is she runs a prospective cohort study on delirium and catatonia, um, where she serves as the co-principal investigator. And so she also runs a number of clinical trials on catatonia and Down syndrome. Um, so she will today give us an overview of about the clinical presentation, the diagnostic approach, and treatment recommendations and epidemiology of catatonia. She will also highlight uh, data from her recently published paper, which is the American Psychiatric Association resource document for catatonia. So with that as the background, the floor is yours, Dr. Wilson.
Thank you very much for that kind introduction, and I will go ahead and get us started here. There we go. So I have no disclosures relevant to this presentation, but I do receive research funding from the NIH, the Department of Veterans Affairs, and from multiple industry partners, mostly in the space of Down syndrome and Alzheimer's disease, which are obviously not related to this presentation today. So for the purpose of this talk, we'll talk a little bit about the history, the gnosiology of catatonia and how we sort of got to the point where we are in present history in terms of our understanding of this syndrome. We'll talk a little bit about the epidemiology of catatonia. I will talk about some of the current research that my lab has been producing in our DCAT study. So that's the delirium and catatonia prospective cohort investigation, where we have studied brain dysfunction, catatonia, delirium, and coma in the context of critical illness. And so we'll talk a little bit about the diagnostic overlap, risk factors, and morbidity and mortality associated with these syndromes from some of our recent research. And then intermixed throughout the presentation, I'll share some of what we produced. And this was really a huge behemoth effort to put together this APA resource document on catatonia, where our hope all along is that this document would increase awareness of what catatonia is, how to diagnose it, how to treat it, and ultimately how to help patients. So many of you have probably seen this image before. It's a famous image from one of Kreplin's early textbooks on schizophrenia. And you can see the individuals pictured here in this image all have fairly classic signs and likely symptoms of catatonia. You can see this gentleman, I don't know if you can see my cursor here, but this gentleman here likely has a catatonic grimace. We see posturing and likely catalepsy. I would imagine many of these individuals who are posturing may have some waxy flexibility. You can sort of imagine some might have a stare, in particular this gentleman who might be sort of staring down, as well as a variety of other classic signs and symptoms, likely of hypoactive catatonia. But what is catatonia? Well, many of you may know this, but just in case you're not as familiar, we'll go through some of the basics. So catatonia is a neuropsychiatric syndrome characterized by marked and oftentimes contradictory changes in tone, motor behavior, volition, and also at times profound abnormalities of the autonomic nervous system, including typically autonomic hyperarousal, where some individuals who have typically severe catatonia can develop malignant features of their catatonia where they may have extreme hypertension, tachycardia, have a fever, and at times require ICU level of care. And in fact, years ago, this form of catatonia was oftentimes called malignant, pernicious, or lethal catatonia because some of those individuals without treatment would unfortunately succumb to the catatonia and pass away typically due to cardiovascular and hypocoagulable complications. And so we now recognize that catatonia not only happens in severe psychiatric disease like formal thought disorders, schizophrenia, as well as affective psychoses, bipolar disorder, or major depressive disorder with psychotic features, but oftentimes now is increasingly recognized in the setting of severe medical illness, neurologic illness, and typically comorbid with delirium and coma. Its prevalence varies widely across medical, neurologic, and psychiatric settings, but in inpatient psychiatric settings, general prevalence estimates range from 9 to 18%, with higher estimates in mood disorders, anywhere from 20 to 25% in the setting of an acute episode of mania. Those numbers are actually quite higher if someone is coming into the hospital with an acute episode of mania and they have psychotic features. You could probably see estimates as high as 40% with patients having some catatonic signs and symptoms. In the general medical setting, up to 10%, if you were to do a point prevalence study on any general inpatient medical ward, probably, on the average, 5 to 10% of those patients, especially if they have delirium, will have some catatonic signs and symptoms. They may not necessarily require treatment, but they're there if you look for them. And certainly in the ICU setting where patients are severely medically ill and have much higher rates of delirium or coma, prevalence estimates from our research and others have suggested about a third of those individuals have catatonic signs and symptoms, and typically high enough to meet DSM-5 criteria for catatonia. So why do we care about catatonia? I mean, we started off the talk sort of recognizing the fact that catatonia was more widely recognized years ago, kind of fell out of favor or was unrecognized for a period of time widely. And then now there's sort of this resurgence and interest. And I think in part it's because, one, we now have some better tools to screen for and recognize catatonia. Our diagnostic criteria from DSM-4 to DSM-5, ICD-10 to 11 have actually changed, in some cases making it harder to diagnose the syndrome in the case of DSM-5, and in some cases easier to diagnose the syndrome in the case of ICD-11. But I think all of that has sort of caused us to be just more aware of the fact that it's happening and how we can recognize it in our patients. But I think more importantly than any of that, we've recognized that catatonia is a preventable cause of death in some individuals, in particular those in long-term psychiatric institutions. There have been papers written about the fact that catatonia is a preventable cause of death in these individuals. And then we recognize now that catatonia is associated with a variety of different morbidities, and prompt treatment, especially in the case of malignant catatonia, can be life-saving. So here are some of the clinical complications of catatonia that we certainly have seen in our patients. This is actually pictured here in this image is a woman in my cohort study who had catatonia, and she gave us permission to share her image here. But I want to always come back to the fact that this is about our patients. And so why do we care about catatonia? Well, it can lead to aspiration events, um, pneumonia, dehydration, particularly around this profound withdrawal that many patients have and who will refuse or not be able to eat or drink. They can develop pulmonary emboli. And in fact, not only are patients oftentimes um, hypoactive or may even be lying still in bed, sometimes for days on end. They can develop this hypercoagulable state, partially related to the immobility, but we also think that catatonia may be a hypercoagulable state. So they get that sort of double hit, and they can develop DVT quite commonly, which unfortunately can lead to pulmonary emboli and death, rhabdomyolysis, secondary to extreme rigidity, hypoactivity, um, which can lead to renal failure, clearly malnutrition related to the catatonic withdrawal. And then if someone's lying still in bed and rigid, they're going to develop contractures after a period of time, which can be quite painful and debilitating to recover from. And then clearly death is a complication in some individuals. So I want to sort of juxtapose these two images next to each other, although they may look quite different. All of these individuals are actually catatonic. And so I think it's important to recognize the fact that in some cases, if you're not looking for catatonia, if you're not appropriately screening for catatonia, you may actually miss catatonia if you're looking for a certain, you know, typical image of catatonia. So I always like to talk a little bit about the history because I think we sometimes think of catatonia as a modern phenomenon, but in fact, catatonia has likely been recognized for millennia. It was not called catatonia until 1874, but it's been recognized in the context of delirium, in the context of other psychiatric illnesses, as this unusual state. And so I'll just point this one example. So Cyrannus of Ephesus was an early physician. He is credited as being one of the first OB-GYNs. And he wrote and practiced in the first and second century AD, and he was the first to describe psychomotor changes appreciated in what now is recognized as delirium. And this really nice quote from him was translated and put in a nice review of delirium by Dr. Lepowski in the American Journal of Psychiatry about 40 years ago, but I think it's still quite relevant now. And what he describes is a patient in the early centuries with likely delirium, but also I want you to see if you think there might be catatonia represented here as well. So I'll just read it briefly, but he says, quiet or loud laughter, singing or a state of sadness, silence, murmuring, crying, or barely audible muttering to oneself, or such a state of anger that the patient jumps up in a rage and can scarcely be held back, is wrathful at everyone, shouts, beats himself, or seeks to hide in fear, or weeps or fails to answer those who speak with him, while he speaks not only with those who are present, but with the dead. So what I would like to do now for just a moment, if you could humor me, is to come off mute and to just pipe in. Are there any signs or symptoms of catatonia that you recognize in this vignette? Anything that sounds familiar? Okay, so he mentions murmuring here. Certainly could just be murmuring, could be verbigeration. So this sort of repetitive repetition of either a syllable or a word or phrase. That also could be potentially could be describing a form of mutism. So he also talks about he fails to answer those who speak with him. So that could be some mutism. Or a form of mutism could be whispering. So that could be describing some of that there. He also talks about these profound psychomotor changes where he may actually be, um, quite psychomotorically agitated. That catatonic excitement and impulsivity might be sort of represented here as well. Yeah. And then just some of this, um, you know, excitement here. So anyways, there may be some clear catatonic signs that are represented even in this early description of delirium. I think probably one of the better examples of a description of catatonia is in A Story of Wall Street, where Herman Melville describes Bartleby, the scrivener, who was essentially a law clerk in early New York. And in the descriptions of him, he actually initially almost seems quite manic, highly productive, highly focused, motivated. And then he sort of burns out into this depressive state where he becomes almost sort of autistic and inwardly focused, unable to sort of describe what's going on in his internal state. And he eventually wastes away and dies, potentially due to this profound catatonic hypoactivity and withdrawal, likely in the setting of a profound depressive episode. And so he describes the scrivener was the victim of innate and an incurable disorder. I might give alms to his body, but his body did not pain him. It was his soul that suffered, and his soul I could not reach. And in the late stages of the condition that Bartleby, the scrivener, was suffering from, he repeated the phrase over and over again, I would prefer not to. I would prefer not to. And so that may represent some of the verbigeration, but also this profound negativism that is a hallmark feature of catatonia, but also represented likely as internal, um, sort of affective experience of profound depression. So this was described back in 1853. This was before a formal description of catatonia had actually been defined. So catatonia actually came into favor and into the medical literature by Dr. Karl Kahlbaum, who was a practicing neuropsychiatrist in Germany. And he wrote about a series, this is actually a picture from his monograph where he described the condition of catatonia in 1874. But he described really a constellation of a variety of signs and symptoms characterized primarily by hypoactivity, but some with hyperactivity. Oftentimes profound deficits and abnormalities of volitional, motor, and verbal behavior. Oftentimes this profound stupor, mutism, staring, posturing, a lot of the classic hypoactivity signs. And so we now sort of link hypoactive catatonia with Karlbaum's classic description of catatonia. So we sometimes may even call that Karlbaum's catatonia, but he actually described much more than that. What's interesting is if you go back and read his initial descriptions of catatonia, not only does he describe catatonic signs and symptoms in these series of 20 some odd patients, many of them had psychiatric illness, but many also had other likely illnesses as well, profound neurologic illnesses, complications of infectious diseases that affected the central nervous system, probably tuberculosis, malaria, neurosyphilis, etc. So even in the early descriptions of catatonia, while they were described essentially in an asylum format, many of those patients actually had underlying medical and neurologic illness. And so Karlbaum actually talked about in his monograph, he called catatonia a brain disease with cyclic alternating course in which mental symptoms are consecutively melancholy, mania, stupor, confusion, and eventually dementia. And some of that may actually seem quite familiar when we think about other psychiatric diagnoses that we treat, schizophrenia, bipolar affective disorder, schizoaffective disorder, et cetera. And we certainly have seen some of these presentations in our patients that we treat on a day in, day out basis, the sort of cyclical or longitudinal kind of course of symptoms that happen and eventually may worsen over time and lead to chronic deficits. But I'm going to point this out because we're going to talk about this slide a little bit later in the presentation. So catatonia, while it was described in 1874 in a very heterogeneous sample of psychiatric and medical patients, it later became sort of subsetted as a form of schizophrenia. And so through work by Kreplin and others, catatonia really became a part of dementia precox and sort of a core feature of some of those syndromes. And in the early DSM, it really became relegated as a subset of schizophrenia. And we'll talk a little bit more about that. And I think in part, this sort of led to writings, in the 1980s. And so sort of saying, where have all the catatonics gone? Like we've read all of this literature about catatonia, but where have all of them gone? And I think what in fact happened is we just made it quite difficult to diagnose catatonia. It didn't go anywhere. We just were likely not recognizing it, and not having a diagnostic construct to put it in. And so if we look at the history, we've talked a little bit about Kalbaum being the first to actually describe the syndrome, but it likely being represented and recognized millennia before. And then in 1896, Kreplin redefined catatonia as a subtype of dementia precox through work by Bloyer and others, and the early DSM 1, 2, and 3. It was recognized as a subtype of schizophrenia. Stouter and others described subsets of catatonia that was lethal and really did some great work to speak about the clinical relevance of catatonia. In the DSM-3R, catatonia was added as a specifier to mood disorders, and that was in part thanks to work by Abrams and Taylor and others that wrote widely about catatonia happening in the context of depression and mania. And then with DSM-4, catatonia was added secondary to general medical condition. And this is in part thanks to writings by Gellenberg and others who really recognized that catatonia was occurring outside of the psychiatric hospital. It was also happening typically across the medical campus in patients with other medical illnesses. And then with DSM-5, unspecified catatonia was added, and the criterion itself for catatonia was changed from a subset of a constellation of symptoms to 3 of 12 items. And this is thanks to work by Max Fink, Stefan Heckers, and others who really advocated that catatonia should have a home of its own. It doesn't quite have its own home, but it has more ways now that we can recognize it and give it a diagnosis. And then with ICD-11, unspecified catatonia was added, and definitions were actually provided for evaluating different signs and symptoms and what that means. And we had a little bit more loosening of the criteria here that added in some pathognomonic signs of catatonia that were unrecognized in DSM-5. So this can be diagnosed using ICD-11 with 3 or more of 15 signs. And so if you look at DSM-4-TR, this is the guidebook that many of us kind of grew up practicing under. This is how we diagnosed catatonia for many years. You had to have at least 2 or more of these 5 kind of grouping of items. And it was actually not hard to make a diagnosis of catatonia using this criteria in someone that you had concern was catatonic. When we moved to DSM-5, while I think this was in many ways a step in the right direction, it actually made things a little bit harder to diagnose catatonia. We wrote about some of that in in a paper we published in Schizophrenia Research about a decade ago now that really talked about the fact that some classic signs and symptoms of catatonia are actually missing in DSM-5 criteria. And so we'll look at that in just a moment. But you can start to see that maybe some patients that you've treated might not meet DSM-5 criteria for catatonia, yet could benefit from treatment with typical treatments. If you look at ICD-11, these are now some of the different codes we can use to code for catatonia, and we sort of outlined how this has changed from DSM to ICD in a nice paper that was spearheaded by Jonathan Rogers in BMC Psychiatry. And you can see the classical descriptions of these signs and symptoms according to ICD-11 and some of the definitions that we gave these classic signs and symptoms to help guide the clinician in recognizing the disorder and appropriately coding and treating for it. In our APA resource document, we also, wanted to recognize the fact that catatonia can be evaluated in a number of different ways. There's um, over 20 different scales that have been published. Many of those are validated measures. Um, Probably the most widely used catatonia rating scale is the Bush-Francis catatonia rating scale. It's a 23-item instrument that you can use at the bedside. It's quite simple and streamlined, and even though you're evaluating for 23 signs and symptoms, most of the time the evaluation can be done within 2 to 5 minutes. So it's quite easy to do. You can do it um, with a patient who's at the psychiatric hospital and maybe experiencing an episode of psychosis. You can do it across the street in the ICU in a patient who is mechanically ventilated. And so some of our work has really tried to highlight just how versatile the tool can be and how useful it can be. And you can see that it screens for a much wider range of catatonic signs and symptoms than even our DSM or even the ICD-11 recognize. And so I just want to point out here, let's think of a classic hypoactive catatonic patient who may actually be quite ill, who could have profound rigidity, staring, and mutism. That patient may meet catatonia criteria, screening criteria using the Bush-Francis, but would actually fail to meet DSM-5 criteria using those same signs and symptoms. So I just want to point that out, that even though the DSM-5 is a helpful diagnostic tool, it's not all inclusive in terms of representing clinically relevant catatonia that may require prompt treatment. I just want to point this out because these are some really helpful resources if you're interested in this topic and want to read more about catatonia. Max Fink is certainly probably the father of catatonia and has done the most that I can think of in the field to write about the syndrome, to really help guide clinicians how to recognize and treat it. And he wrote some wonderful textbooks on the topic. He also partnered with a medical historian, Dr. Edward Shorter, and wrote this terrific little book, The Madness of Fear, A History of Catatonia. It's a very quick read, and if you're at all interested in the history of medical conditions, you should read works by Dr. Shorter, but this one in particular is quite good. So as I mentioned before, we put together this resource document, and I just want to highlight here some of the collaborators on this paper. And several of them are actually at Harvard programs. So I just want to, give a shout out to the incredible colleagues who put in a ton of work to get this resource document out into the literature. So as we think about evaluating for catatonia, perhaps you might use the Bush-Francis catatonia rating scale and screen for catatonia. But it's also helpful to think about a differential diagnosis. What else could be on the differential, if it's not catatonia? And so it could be things as simple as delirium, dementia with profound mutism and withdrawal, locked-in syndrome, Parkinson's disease, serotonin syndrome, and neuroleptic malignant syndrome, which is not represented on this list here. Serotonin syndrome and NMS are actually conditions that have catatonia as a part of the diagnostic criteria. And in fact, serotonin syndrome and NMS may be malignant catatonia precipitated by different stimuli. Stiff person syndrome is a condition that's come into the mainstream literature. Celine Dion is suffering from stiff person syndrome, so people are increasingly recognizing it. And then, of course, mania, depression, and other conditions certainly would be on the differential. This is really outside the scope of this talk here, but I wanted to point it out to you if you are interested in the neurobiology of catatonia. A lot of people have written about this widely. Probably some of the best in the literature is written by Dusan Herjak, Georg Northoff, Jonathan Rogers, Sebastian Walter, and Stefan Heckers have really done the most to kind of move this field forward in terms of our understanding of the neurobiology of catatonia. But we tried to summarize some of that literature in the resource document for you. And so we've tried to put it in I think a bite-sized sort of digestible format that could be helpful for the clinician evaluating and thinking about catatonia. So if we think about treatment of catatonia, it's quite diverse in terms of the treatments that you can use. Um, I would suggest that if you have clinical suspicion that someone is catatonic, you might want to think about doing a lorazepam trial. And so a lorazepam trial includes typically 1 to 2 milligrams of either PO, IV, or IM administration of lorazepam to a patient with catatonia. And so I usually give it in the least invasive way. If a patient can take medication by mouth, then I give it to them PO, and then I reassess response. If they are unable to take PO or unwilling to take PO, you can give it IM or IV. Most patients will actually respond quite favorably to a benzodiazepine trial, and then you can go ahead and schedule medication for a period of time until symptoms improve, and then taper them off of that. But for a subset of patients, either the catatonia is only partially responsive to lorazepam, or it may fail to respond to lorazepam, and so ECT would really be the next line treatment if you have ECT readily available. If you don't have ECT readily available or it's not available at your site, you can certainly skip down to some of these other options. So glutamate antagonists such as amantadine or memantine can be quite effective as augmentation to lorazepam in a catatonic individual. For some individuals, particularly if they have underlying bipolar diathesis or a lot of agitated catatonia, you can use an antiepileptic. My first go-to is valproic acid. I just feel like it works the most effective, but you can certainly try other things. And then certainly if a patient has underlying psychosis, I oftentimes am starting an antipsychotic, typically an atypical antipsychotic, usually olanzapine or aripiprazole, first line, while I'm also initiating lorazepam treatment. I will say though, however, in patients with profound excited catatonia or malignant catatonia, or in those with severe rigidity at the onset of catatonia, I may wait briefly before starting an antipsychotic, even in a psychotic individual, so that I can treat the catatonia, at least initially manage the autonomic hyperarousal and rigidity before putting an antipsychotic on board. But we can talk more about that in the Q&A if you have questions about that. Again, I just want to point out some of the complications of catatonia and why it's so important to treat it early and to recognize it. And we highlighted some of those complications here in the resource document. In a separate review of malignant catatonia for the intensivists, we outline, again, some of these complications, but also talk about management considerations. So for any of you that may work with hospitalized patients, this might be a useful guide to think about, when should I think about anticoagulation in a patient with hypoactive catatonia? Are there other medications that we may use in the ICU that may be more efficacious? And so we talk about some of that in the review document. I think it's helpful to understand that catatonia oftentimes doesn't just happen in isolation. There are typically a variety of predisposing and precipitating factors that can lead to sort of the perfect storm of catatonia being a phenotype that emerges out of usually multiple risk factors. And so we outline some of those here. I think this is particularly helpful if you're managing medically complex folks. Sometimes it really is just as simple as someone having a first episode of psychosis and then they develop catatonia in the context of that severe presentation of psychosis or other mood states. But in medically complex individuals, it oftentimes is a combination of predisposing and precipitating factors. If you've not used the Bush-Francis Catatonia Rating Scale before, here are some of the signs and symptoms that are screened for. I would strongly encourage you to look at the University of Rochester. They have brief videos, like 1 to 2 minutes, where they actually display how they evaluate for each of these different signs and symptoms, and it's incredibly helpful. We have a link to that at the back of the resource document if you want to see how to get to their website. So this is probably an image that many of us may recall from Awakenings, where a patient is suffering from encephalitis lethargica, really a form of catatonia, and then sort of awakens briefly after receiving some medication. But again, this is the patient these are the patients that we treat at Vanderbilt in the context of our research. So I'm going to talk a little bit about some of the motivation for my research, and then we'll spend the rest of the time talking a little bit about some of our current findings. So as a as a fellow in consultation liaison psychiatry about a decade ago, I really got kind of stuck on this DSM criterion where they talked about how catatonia must be sort of clinically distinct from delirium and how it cannot be diagnosed exclusively in the context of a delirium. And as I sort of recalled the experiences I was having as a psychiatry resident and then as a CL fellow, I just recognized that that isn't how we sort of recognized patients in the clinical setting. And so I wanted to see, could we actually, if we ignored this criterion of saying you can't diagnose catatonia exclusively in the context of delirium, could we otherwise recognize catatonia in the context of delirium? And so that really motivated some of our work. And as I looked back at the literature, I realized this wasn't a new concept. So even Kalbaum and Kreplin described delirious signs and symptoms amongst patients that also had profound psychosis and catatonia. The encephalitis lethargica, which I pointed out earlier, is really a profound state of both hyperactive delirium and catatonia, delirious mania, NMS, serotonin syndrome, which I've already referenced, and then autoimmune and paraneoplastic encephalitides, which have come into more mainstream thinking now, especially with forms that are now widely recognized, anti-NMDA receptor encephalitis and others. These patients have profound co-presentations of oftentimes delirium, catatonia, and other autonomic and neurologic signs and symptoms. And so you can see here in this image from the New England Journal, this was a review of serotonin syndrome, and this might look quite familiar as you think about other conditions like NMS. And so our lab has been really interested in trying to understand the overlap of these forms of brain dysfunction where they can be clinically distinct and where they have shared features. And so this is really the work that has prompted the past decade of my lab's investigation. Some of this was spurred on by reading really interesting papers by Andy Francis and others who wrote about a clinical series of patients who had both delirium and catatonia, and they talked about how this really led to diagnostic and treatment uncertainty. And so this really led to our work, and we were motivated by the fact that this sort of diagnostic conundrum potentially led to a lack of recognition of catatonia in the medical context and could hamper research. So we wanted to push through that and see if we could do that. So this led to the delirium and catatonia prospective cohort investigation. And the first series of 136 patients from our study was published in Critical Care Medicine in 2017. And so we started enrolling patients who were admitted to Vanderbilt University Medical Center. They had to be 18 years or older. And they were recruited from one of four of our parent studies. So they were either in one of our randomized clinical trials or one of our prospective cohort studies. They were all critically ill, admitted to a medical surgical cardiovascular trauma or burn ICU with a critical illness indication. So typically they were either requiring mechanical ventilation or were in sepsis or shock on vasopressors. So the objective of the initial study was to describe the association between delirium and catatonia in critically ill patients and to determine diagnostic thresholds for the Bush-Francis Catatonia Rating Scale in the ICU. So we assessed coma using the Richmond Agitation and Sedation Scale. I'm not going to go into this too much, but basically if a patient was either -4 or -5 on the RASS, they were considered to be in coma. And this is actually consistent with our clinical definitions of coma at Vanderbilt. We assessed delirium using the confusion assessment method for the ICU or the CAM-ICU, and it's a quick bedside screen that our nurses are trained on doing. They already do it every shift at least once, and so we also had a study team evaluate patients for delirium using the CAM-ICU. We evaluated catatonia using the Bush-Francis Catatonia Rating Scale and mapped it to DSM-5 criteria. So patients were considered catatonic if they met DSM-5 criteria. From our first 136 patients, you can see that median age at enrollment was 59 years. They were all critically ill with a number of medical comorbidities, and you can see sort of the top reasons for admission to the ICU. So these were quite medically critically ill folks. So when we looked at just the distribution of acute brain dysfunction in this population, of those who met criterion for delirium, about 40% were also catatonic. And of those who were catatonic, 91% were also delirious. And there was this profound overlap of delirium and catatonia presentations in the ICU. About a quarter of the patients who were enrolled never experienced delirium or catatonia during their ICU stay, and about 3% experienced catatonia only. But what was really interesting is that when catatonia did occur and met DSM-5 criteria, it was oftentimes in the setting of delirium. And you can see on the Bush-Francis Catatonia Rating Scale the prevalence of these signs and symptoms in these patients. So you can see just amongst delirious patients in the black bars how much more prevalent all of these signs and symptoms were as opposed to non-delirious patients. Again, just sort of speaking to the fact that there may be this kind of continuum of severity of brain dysfunction, and perhaps those that were, profoundly delirious were also developing catatonia. When we looked at the probability of being delirium according to catatonic signs and symptoms present, if someone had 3 DSM-5 catatonia signs present, so essentially they met DSM-5 criteria for catatonia, they had 28 times the odds of being delirious at the same point in time. And this was using individual kind of matched delirium and catatonia assessments amongst the patient population. Again, just speaking to the profound overlap of these two syndromes. When we looked at catatonia cut points on the Bush-Francis Catatonia Rating Scale, we had always a priori had some concerns that the Bush-Francis may be too generous in scoring patients who had particularly hypoactive delirium. They might sort of inadvertently screen them in for catatonia, even though they might not actually be catatonic. And what we found is that you really needed a higher cut point than 2 signs and symptoms, which is the traditional Bush-Francis cut point. So we found really either 4 to 5 symptoms would be sort of the sweet spot in recognizing clinically relevant catatonia that might require a change in treatment, such as a trial with a benzodiazepine. And this is really clinically relevant because in the ICU space, we've been moving away from using benzodiazepines as a part of the sedation regimen. And in fact, for the past couple of decades, there's been tons of literature by pulmonary critical care anesthesiology folks writing about the fact that by giving people benzodiazepines in the ICU, we're actually causing a lot of morbidity and mortality. We're essentially causing delirium, we're worsening delirium, we're worsening brain dysfunction, and that's leading to a variety of poor outcomes. So, we wanted to be quite cautious in our messaging of, when should we actually recognize clinically relevant catatonia and potentially administer a benzodiazepine. So we felt like 4 to 5 signs was a fair estimate. So we concluded from this initial study that catatonia was quite common in critical illness and co-occurred with delirium, and that catatonia should be kept on the differential, especially when non-psychiatrists are sort of seeing these patients, they may not always think of catatonia. And especially in cases of what's oftentimes referred to in the literature as refractory delirium, that we think about catatonia. Could this be refractory delirium because it's unrecognized catatonia? And then this led to some reconsideration in the ICD-11 criteria, and I was happy to be a part of that team that moved us a little bit further along in recognizing that catatonia can occur in the setting of delirium. So I want to pivot just a little bit and talk about antipsychotics. So this has always been a bit of a conundrum for me, in particular when we're treating patients with psychosis who also have catatonia. When should we be using an antipsychotic and when should we perhaps wait? Well, Some have written that we should use them. Some have written about the fact that we should be judicious in using them. And this led to me kind of thinking about the history of antipsychotics use. And we don't really have time to think about that all together. But if we look at just like the timeline of development of antipsychotic drugs over the years, there's been this rapid proliferation of antipsychotics, first typicals, then atypicals. And I think we've come a long way in terms of developing therapeutics that are more effective for our patients, but also have lower side effect burden. This has probably led to a rise in antipsychotic use amongst non-psychiatrists across the medical settings. And in fact, in the ICU settings, um, antipsychotics are being used ubiquitously, uh, typically for non-psychosis indications. And so this very potentially overuse of antipsychotic medications for non-psychosis indications has led to some challenges for patients. And so this is an image from the NMS review from the New England Journal. And this audience probably needs no introduction to this, but NMS is a life-threatening condition that can require ICU level support to treat complications of neuroleptic malignant syndrome. And as I mentioned before, some of these cases can actually look like malignant catatonia. And so one of the things that we started to think about in our lab is, are antipsychotics in the context of critical illness potentially a risk factor for developing a maybe subclinical or clinical catatonia, maybe not to the level of NMS, because we're typically recognizing that pretty quickly. But could antipsychotic use in the context of routine clinical care in the ICU lead to development of catatonia in these patients? And I've talked already a little bit about this sort of management conundrum, but I've listed some references here if you want to look at those yourself. Some patients have had poor outcomes with antipsychotics in the context of delirium treatment. And then we've recognized that some patients actually respond to partial agonist and antagonist in the context of catatonia, which just sort of further muddies the water in terms of trying to appreciate are antipsychotics helpful or not helpful. And then what I've already sort of referenced here is that antipsychotics are widely used. 65% of intensivists say that they used antipsychotics regularly. If we did a point prevalence study of almost any ICU at this point in time, at least 10% of those patients would be on an antipsychotic, and about 9% of all general ward patients are receiving antipsychotics, oftentimes for sleep, anxiety, panic attacks, etc., delirium. And so, we really wanted to understand whether this was potentially causing catatonia. Our lab published a paper from the Mind USA trial that actually showed that antipsychotics, risperidol versus ziprasidone versus placebo, had no effect on delirium outcomes, either delirium, same day, next day, or survival outcomes. Yet, despite work by our lab and others, other use remains ubiquitous. I'm going to skip over this for the sake of time, but I just wanted to point out that there's a lot of underlying neurobiological theories regarding, neurotransmitters, effects on catatonia. Dopamine blockade is certainly one of those theories. And so we sort of hypothesize that, you take a vulnerable patient, you take someone with some predisposing risk factors, they're potentially critically ill, they receive an antipsychotic medication, maybe because they developed delirium. This leads to profound dopamine blockade, and then a subset of these individuals may develop some catatonic signs and symptoms. So we wanted to explore whether exposure to antipsychotic medication is associated with less days alive and free from catatonia. And we hypothesized that it might do just that. So this was an analysis from our delirium and catatonia prospective cohort investigation. We created these statistical models where we adjusted for potential confounders of the association of interest, and you can see these are mostly clinically relevant confounders of interest. We developed an outcome called catatonia free days, and so this was In line with a lot of what the critical care literature does when they develop delirium-free days, delirium coma-free days, ventilator-free days, it's a way of partially accounting for the increased mortality that happens in the ICU stay. And so what you do is you take a clinically relevant denominator. And so for us, that was 14 days. You subtract the days that the patient had catatonia and subtract the days that the patient was deceased. And that's your catatonia-free days. So those are days alive and free from catatonia. And this was an ordinal outcome. We created an adjusted proportional odds logistic regression number where we adjusted for all the relevant confounders of interest, looked at a main model, which was 14 days from study enrollment, and then sensitivity analyses, which were 5 days from study enrollment. And I'll just point out here the way that the outcome was modeled and the way that the polar model itself models things, it's a little confusing. So if we get a lower odds ratio, usually you think of that as protective, right? That's better. But in this case, because it's a lower odds of more days alive and free from catatonia, that's actually a worse outcome. So a little bit about the results. I'm going to skip over here this for the sake of time, but I just want to point out that we had a lot of trauma patients in this cohort. So about half of the overall cohort had a trauma indication. And a lot of those patients who were critically ill received an antipsychotic in the context of their routine clinical care. And I just want to point out here that amongst those who ever experienced catatonia in the ICU stay, you were much more likely to have been exposed to an antipsychotic during your ICU stay. If you look at the distribution of catatonic signs and symptoms amongst those present, you can see here that the DSM-5 items are much more common. However, there are a number of non-DSM items that are represented in the Bush-Francis that were quite frequent in this population. And if we just look at those that are catatonic only and look at their distribution of signs and symptoms, again, there are some familiar ones, rigidity, withdrawal, staring, that are not represented in the DSM-5, but were quite common in this patient sample. So if we look at those that were ever never exposed to antipsychotics, you can see here in the 14-day model, if you were exposed to an antipsychotic, your odds ratio was 0.49, which was statistically significant. So if you were ever exposed to an antipsychotic, you were much less likely to have more days alive and free from catatonia than if you were not exposed to an antipsychotic. And that effect was consistent and even stronger in the 5-day model, speaking to the fact that this may be even more of an acute effect. So in patients who are even more critically ill, being exposed to those antipsychotics in the acute period could be a risk factor. If we look at cumulative dose of antipsychotics, those effects held up as well and were even more profound. You can see that the amount of medication that patients were receiving was quite high. So patients in our ICUs in particular were receiving a lot of antipsychotics, mostly to actually minimize benzodiazepine drug exposure. So as groups like the ICU Liberation Initiative and others were really saying we have to decrease benzodiazepine exposure, they turned to other medications. And in many cases, these are antipsychotics. So these patients are receiving a lot of antipsychotics, and it's leading to a lot of catatonic signs and symptoms. So we just pointed out here that, we really should be much more judicious in how we expose patients to antipsychotics, particularly those without a psychosis indication or without, bipolar disorder or something where an antipsychotic might be indicated. But in these patients in the ICU, we should be much more judicious in using antipsychotics because we may in fact be causing some catatonia in these patients. I'm going to skip over this mortality analysis, but I will just point out the fact that we also looked at mortality, and catatonia was not a risk factor for either the following day mortality or mortality out to 1 year. But coma itself was actually a very strong predictor of next day mortality and 1 year mortality. And I think that just speaks to the profound brain dysfunction that's happening that likely represents severe systemic illness. if we look at, different mechanisms underlying delirium and others, we can learn a lot from the delirium literature. And so when I'm not researching catatonia, a lot of times I'm thinking about delirium. So I think about these conditions side by side in parallel. And one of the things I've learned from some of my colleagues who have looked at delirium as a risk factor for long-term cognitive impairment is that perhaps, much like you can see represented in this conceptual model here of someone having an acute illness, having systemic inflammation, which leads to a lot of CNS inflammation, which probably further drives delirium, neuronal injury, and apoptosis. This can lead to an accelerated cognitive decline in individuals who recover from a critical illness. And in fact, about a quarter of individuals who survive a critical illness and experienced delirium will go on to develop a long-term cognitive impairment akin to Alzheimer's type dementia. And so our lab is actually doing some of that work to try to understand what is the underlying neurobiology leading to accelerated cognitive decline and dementia in delirium survivors. And I think there's a lot that we can learn from that in the catatonia space. So there's a lot of work that would suggest that there is a lot of neural inflammation, neuronal cell death, and potentially this sort of delirium accelerated dementia that may happen in a subset of these patients who experience delirium and also likely catatonia. So what we did in our lab is developed a multiple linear regression model that we adjusted again for a number of confounders of interest. And we modeled exposures, delirium, catatonia, and coma, and looked at the outcome of the repeatable battery for the assessment of neuropsychological status, or the R bands, which is a nice general cognitive battery where we have population and age-adjusted norms for in this population. And so we assessed survivors from DCAT at 3 and 12 months after hospital discharge. And so you can see the flow of patients throughout the study. We started with an in-hospital cohort of 338, 163 survived to 3-month follow-up, and then 123 survived to 12-month follow-up. And I will say that this excluded number here between hospital discharge and 3-month follow-up was actually all due to mortality. So it just sort of speaks to just how severely ill these folks are. And the same would be true for here. There were a few that actually were just unable to come in for follow-up, but the vast majority actually expired. So if you look at our in-hospital, and I'm just going to skip over this for the sake of time, but again, if we go back to this kind of conceptual model of the overlap of these form of brain dysfunctions, you can just see how common all of these were in our cohort. If we look at 3-month results, only delirium and coma were actually significantly associated with lower R-bands global cognitive score. Catatonia was not when it was included in the overall model. And again, these were the adjusted models. When you look at 12 months, only coma was significantly associated with reduced R-bands global cognitive score. If you look at the R-bands score by age groups at 3 and 12 months, you can just see, so 100 here, this is the population norm, and then this is one standard deviation below, one standard deviation above. Lower scores are actually worse. So you can see just looking across the cohort, these patients are profoundly impaired. Even just having a critical illness, they have profound impairment. And so one of the things that we had always suspected before we did this analysis is that as we have these vulnerable individuals who come in, have a precipitating stressor, develop delirium or coma, a subset of those will go on to develop catatonia. And so if we think about delirium and coma as on the causal pathway to developing catatonia, you actually don't want to adjust for that. If you adjust for delirium and coma, you may be adjusting for any effect that catatonia may have on the outcome. So a priori, we had actually planned to look at this in a model where we removed delirium and coma from the model and looked at catatonia's effect on R-bands global cognitive score. And so if you just look at the presence of catatonia in the yes category here, those patients with catatonia, especially in the younger age groups, they seem to have even more profound effects at 3 months on their R-bands global cognitive scores than those without catatonia. And the same is true at 12 months. So that effect seems to persist. When we looked at this in a sensitivity analysis, several age groups, catatonia's presence in the hospital was strongly associated with reduced R-bands global cognitive scores and cognitive impairment at both 3 and 12 months. And so this kind of makes me go back to this earlier quote by Kalbaum about, well, where catatonia may be a brain disease with cyclic alternating course that eventually results in dementia, that may be some of what we're seeing in this subset. So certainly these results need to be replicated and validated. We're in the process of preparing this for publication, but I thought it was an interesting thing to share with you all because it may represent the fact that catatonia may not just be a benign reversible condition, but especially in a subset of individuals, and certainly in those with accumulating risk factors like delirium, it may actually represent a form of brain injury. And so I'll just finish. I'll just finish here and say thank you for your time and attention. I want to thank our lab and our funding sources, as well as the VA, where I spend a lot of my time. They have also been an incredible supporter of this work. So thank you for your attention.
Thank you very much, Dr. Wilson, for a really comprehensive summary of a fascinating and very important field. I'm sure there are a number of questions from the audience, but let me start with one. You made the very important distinction of people who present with catatonia who are diagnosed in medical settings who tend to have delirium. They don't do well on benzodiazepines like lorazepam, and they don't do well at all with antipsychotics. So, but on the other hand, those who are seen in psychiatric settings like psychiatric inpatient or maybe even outpatient settings, they may be a different species altogether, I suspect. And are there any biomarkers that can help us distinguish between those two? For example, would EEGs look different between these groups? Has anyone looked at the question as to whether EEG slowing, non-specific slowing on EEG, might be a way to distinguish between delirium with catatonia versus catatonia without the delirium? So,
You're asking a really terrific question, and I will give you an unsatisfying answer. The literature, there's not enough evidence to guide the use of a biomarker in distinguishing whether someone is catatonic or potentially not catatonic. There are small case series of EEGs that have discrepant results. So there's not a consensus. There have been no large, robust studies that have been able to identify a clear biomarker, such as EEG, to help us diagnose catatonia. So we still have a lot of work to do in order to identify a biomarker that could guide diagnosis and treatment.
okay, great. See, are there other questions from the audience? Please unmute yourself and show yourselves and ask the question, or you can place them in the chat also. Let's see if there are any in the chat.
I have a question about what you shared in terms of the use of antipsychotics in the ICU setting, and then how that relates to the catatonia-free days. You might have mentioned like when you showed the confounder slide, but I was wondering because type of patients who are getting antipsychotics more in that setting, probably there are like fundamental differences in terms of like what type of struggles they have as well, right? So I was wondering if you can share a little bit more about that. And also the other part is because so some of us, we see more catatonia cases in like non-medical hospital settings, right? Psychiatric setting, inpatient or outpatient. So in terms of how I was wondering how you think about the utility of antipsychotics in catatonia treatment and also timing of it for more of a psychiatric patient population without like critical medical illness going on.
Excellent. Okay, so I'll address your first question first. Yes, so I think there may be some important differences, excuse me, in those who received antipsychotics versus those who did not receive antipsychotics in the ICU setting. And in fact, what we found is that a third of the overall cohort had a traumatic brain injury at the time of ICU admission. Um, Most of those actually received an antipsychotic because they went to the trauma ICU, and a part of the trauma ICU admission order set, it includes Seroquel. Quetiapine is a part of that order set. And so most of those patients will get quetiapine along with gabapentin and other things that every patient just gets. So I think that is likely an important confounding factor. And my statistician is actually running a sensitivity analysis where we adjust for traumatic brain injury. So that I think is an important confounder and probably one of the most clinically relevant ones. In regards to catatonia treatment and use of antipsychotics in the primary psychiatric setting. So I will say that even though I presented this data from the ICU space, right now I'm practicing clinically in our psychiatric hospital and in our outpatient setting. So clinically, I'm right there with you. And I think use of antipsychotics in many patients with catatonia, even with pretty profound catatonia, can be done safely. You just have to be quite careful. So I'll give you an example of a patient who was just on my first break psychosis team in the psychiatric hospital. He had come in after, so he had no prior psychiatric illness other than a childhood diagnosis of ADHD and depression, which was being treated with Vyvanse and Lexapro. And then he had started consuming large amounts of marijuana, and for about a week prior to admission had been intensely focused on a computer project where he was trying to develop a large language model to automate pricing and marketing in a different country for a company that he was developing. And he became so fixated and focused on that and using marijuana, not sleeping for a week, that he came in after he had essentially assaulted someone and destroyed property and was arrested. So he came in acutely manic and psychotic. He had numerous delusions, was responding to internal stimuli, and was quite agitated. He was also profoundly catatonic. And so when he came to me, he was repeating a phrase over and over again. He was very psychomotorically agitated. And he was at times mute and refusing to eat and drink. So we needed to promptly treat his catatonia, but I also had to address the psychosis. And so I ended up starting with risperidone for him. And there were a couple different reasons why, but I wanted to go ahead and start something that I thought might be effective very quickly to address his profound disturbances of thought. I also started him on Ativan 2 milligrams TID. So he was quite hypertensive and tachycardic when he came in. That may have been driven by the mania and anxiety, but also I couldn't rule out the catatonia. And I was not able to physically evaluate him because he was so agitated. Very quickly, his catatonia lysed. Within about 24 hours, his catatonia had resolved. And so I was able to titrate his risperidone a little bit more quickly to address his disturbances of thought, and then I added on valproic acid to address the mania. So with him, that's a good example of his psychosis was so hard to ignore and was such a point of suffering for him that I needed to go ahead and treat that, but I also treated the catatonia. I have another patient who was so mute from the catatonia and was lying in a fetal position in bed that I couldn't actually know exactly what was going on. was she experiencing psychosis? She had no history of psychosis. Was there some other affective disorder that was going on? But the most obvious thing was her profound hypoactive catatonia. So I went ahead and treated her catatonia also with Ativan. And her catatonia lysed, and then it became very clear that she was profoundly delusional and was experiencing psychosis. So then we added on olanzapine for her. Um, and so there's no exact right or wrong antipsychotic that you can use in these cases. It literally, just depends on the patient in front of you and what you think is clinically indicated at that time. But usually my go-to is an atypical. The only exception to that would be I had a patient come in who was pregnant. She was 22 weeks pregnant, manic, psychotic, catatonic, and hadn't had no prenatal care. I initially started her on some Haldol just because that is generally what I will use in a pregnant female with psychosis. But unfortunately, her catatonia got much worse to the point where I was about to send her to the medical center because she was experiencing a lot of malignant features. I took off the Haldol, started her on Ativan, and then initiated some olanzapine, and she did quite well. We ultimately did ECT for her because her symptoms were very slow to respond. But within 4 treatments, I was able to discharge her from the hospital.
So can I ask you on that first case? You know, as I understood, you treated her with risperidone and lorazepam, and she got better.
Yes.
How do we know that she responded to the risperidone and not to the lorazepam? So the meta point that I want to raise there is, would you say it might be better to do one thing at a time and first give a benzodiazepine like lorazepam and see what the response is? And of course, like in your second case, the delusions become evident when the person begins talking, right? That is when you would start an antipsychotic. So should there be a chronological order in catatonia where you start a benzodiazepine or even a non-benzodiazepine like zolpidem first? Give it
Mhm.
some time, wait and find out the underlying diagnosis of a psychosis and then only start an dopamine blocker.
Excellent point. In an ideal setting where we have, excuse me, where we have more time, um, I do prefer a very methodologic, systematic approach where you start one treatment at a time, observe its response, benefit,
Yeah.
or harm, and then you add on additional treatments. For that individual, he actually had received some lorazepam in the emergency room and had some improvement, temporary improvement in his catatonic symptoms that then reemerged when he was admitted overnight and did not have lorazepam. And so there was sort of a combination of factors that were contributing to why we made that decision. But yes, in an ideal setting, you would start one medication at a time.
Yeah. Okay. Other questions or thoughts from the group? Yeah, John. Yes.
I noticed that there's a lot of behavior overlap with some of the symptoms in catatonia and autism, and I'm wondering if you saw that as a subset of your cohort, and if you had sort of thoughts and comments on if that impacts your approach.
Excellent question. So autism and other neurodevelopmental disorders, including Down syndrome, have a lot of catatonia in their presentations. We excluded autism. That was one of the exclusionary criteria for the cohort, and most other psychiatric illnesses were exclusionary criteria for the critical illness cohort because of some of the outcomes that the parent studies were interested in. So those patients were actually excluded from the DCAT cohort. There are individuals who are doing some really cool cutting edge research on catatonia and the treatment of catatonia in autism. So my colleague Josh Smith at Vanderbilt has written widely on this topic. And there are a lot of patient advocacy groups also that are focusing on recognizing and treating catatonia in the context of autism. And so if you're interested in that, the Catatonia Foundation has been sharing some information about how to get involved. Um,
Thank you.
yeah.
So there was a question in the chat. Do you see differences in outcomes between antipsychotics with higher versus lower dopamine D2 blockade potency? I think you already answered that a little bit, but you might want to expand on that.
I don't know that there actually is literature that supports one over the other. It's mostly been based on clinical experience and case reports that suggest that there might typical antipsychotics may lead to some initial clinical worsening, especially in certain forms of catatonia, like hyperactive, agitated, or malignant catatonia. So that's generally why we've taken the approach of using atypicals, which are generally tolerated better in the acute catatonic phase. I don't know, though, that there are any reports of outcomes, long-term outcomes, in terms of one medication over the other.
Hi, Dr. Wilson. This is Tao. I asked the questions in the chat. I think I meant a little more, I'm glad you addressed that answer. I was curious, but particularly in the study that you did with the patients in ICU, and I'm wondering if you see more catatonia in patients who get Haldol versus, quetiapine,
Mm.
initially in the ICU cohort.
Yeah, so we have not analyzed that data, so I can't actually give you an answer there. What we did, though, is that because patients are oftentimes receiving a mixture of Haldol, like, so for example, the typical ICU patient in our study was oftentimes getting quetiapine PRN throughout the day for anxiety, sometimes at night for sleep, and then when they had breakthrough severe agitation, typically related to like hyperactive delirium, they would oftentimes get IV Haldol. So they were receiving both, which made it quite difficult to kind of disentangle, is the catatonia being worsened by the Haldol, or is it being worsened by the quetiapine, or just the overall load? And so what we did is we converted all of the antipsychotic drug exposure, regardless of if it was typical or atypical, and converted it to haloperidol equivalent. I think in the future, though, there should be research that could address that question, and that's a quite valid one.
Thank you. So if I may ask a practical question that occasionally comes up. When there are patients who have severe catatonia, and especially if it is someone who has a recurrent problem like that, and the person, after developing the catatonic episode, they doesn't respond to the standard treatments, and you have to go to ECT. It becomes a challenge how to get any kind of consent in such individuals. And so one idea is to get an anticipatory consent. Do you have any experience with that? In people who have recurrent catatonia, when they are non-catatonic, to get an agreement from them that if you have a severe spell again, we might give ECT. Would that work?
Essentially a psychiatric advance directive.
Yeah.
Yeah, we don't do that at Vanderbilt. So what we do at Vanderbilt is we identify a surrogate decision maker. If the patient does not have capacity to consent, then we use a surrogate decision maker. And so that surrogate decision maker is typically a next of kin, but sometimes could be someone from the hospital if they have no other outside contacts. And we typically have to get that before.
So in the absence of a guardianship, this how does that work? So is it a doable to get, go ahead with ECT with a family member's consent?
Cash, I'm so sorry, because I'm just thinking it might be state specific. Like I would imagine there's state laws that govern capacity and consent to treatment and research and all that. But I'm very intrigued by I apologize for popping in. I'm Margaret Geyer. I chair the DMH-IRB, so I'm sort of listening in a few different ways here. Thank you so much for this talk. So,
Absolutely. And, you know, that's an excellent point about capacity. So, what we did for the research participants is most of the time, the vast majority of time, the participant did not have capacity to consent because of their profound altered mental status. So, we had a surrogate decision maker, um, you know, essentially consent the patient. And then many of the patients actually regained capacity to consent. And so we re-consented them, and they were given the option to decline. But in terms of ECT from a clinical perspective, many of our patients have capacity to consent. It's only if they don't that we then identify a surrogate decision maker.
Yeah. So we have another 3 or 4 minutes left.
I have a
I
quick
have
question.
Yes.
oh,
Yeah, go ahead, Esther.
Okay, great. Thank you. You know, we're sometimes seeing, I work with, in a team that works with people with psychosis and serious mental illness, and we're sometimes seeing later onset of psychosis, not in a typical first episode. And some of those people sometimes, I'm sort of in some amalgamation, but present with what could be construed as really intense negative symptoms of psychosis. And sometimes we wonder, like, is this a catatonia? How do we distinguish? How do we figure it out? Because the treatment would be so different. I don't know if you have any thoughts about how we can like what we should have an eye out for.
Yeah, I think you're bringing up an excellent point there that not only is there diagnostic and symptom overlap between delirium and catatonia, but also between catatonia and psychosis and other psychiatric disorders. And so I think you just have to use your clinical judgment and you have to look at the entire clinical picture and say, could these symptoms be explained by their psychosis wholly, or potentially are there enough pathognomonic clinical signs of what looks like catatonia that we might actually want to initiate a lorazepam trial. And so we actually had a very similar woman on our team who came in her late 40s with her first episode of psychosis, a lot of prominent delusions that was impacting her ability to work and care for herself. And then as we were treating her with an antipsychotic, we were actually using aripiprazole. She developed some very clear negativism and then ultimately started having some perpetuation. And so that was what clued us in. I actually think she's developing some catatonia. So we used a very low dose of Ativan. I think it was 0.5 mg, 3 times a day. It lysed her symptoms. She discharged from the hospital without the lorazepam.
Thank you. Thank you very much.
You're welcome.
Time for one last question from anyone.
Yeah, I have another question. This might be a little bit irrelevant, but since like you are in catatonia space, like I was wondering if you have any sense or thoughts, if there have been any sort of a trends or changes you notice in terms of instance or prevalence of catatonia. Because some of my work involves inpatient coverage, and we like inpatient attendings. You know, we talk about like it feels like catatonia cases have become much more prevalent over the past couple of years. So I share that in like so we have like an early psychosis work group through Child Psychiatry Conference. So kind of talked about that with some other colleagues from other states, but like actually there was some that like a shared sort of sense, like everything is anecdotal, right? But it feels like it has become much more prevalent, and we are seeing more and more of challenging cases as well. So I was wondering if you have any thought about that.
Yeah. So I don't actually know whether catatonia has truly become more prevalent, or if we are just recognizing it more and diagnosing it more. I do think that there has been a huge push over the past 10 to 15 years to improve recognition and evaluation of catatonia. A lot of that started back in the late 90s when Andy, Francis and George Bush published the Bush-Francis Catatonia Rating Scale. I mean, really before that, we were relying on DSM criteria or other scales that were meant for more niche populations. So I think largely what's happening is that we now have effective tools that are easy to implement at the bedside and screen for catatonia, whether it's the Bush-Francis or something else. And so I think we're just recognizing it more. I do think that as we're recognizing it more, we're also seeing more severe cases. I don't know if some of that is because there's a push to use more antipsychotics early in maybe cases where they might not be indicated. So at least in the ICU population, that's what we're seeing. But it certainly would be a very interesting study for someone to look at that and actually look at the prevalence change over time.
Last question. Is clozapine any better than other antipsychotics because of a D1 effect?
Yes, I'm so glad you brought that up. So, clozapine is a wonderful choice for someone who has psychosis and repeat episodes of profound catatonia. It may actually treat the catatonia itself. I will go early to clozapine in patients who have repeated episodes of severe catatonia. And you probably know this, but clozapine withdrawal, if someone was to suddenly come off their clozapine or it be stopped or not restarted when they come into the hospital, those patients can present with profound catatonia
Yeah, I've
as a
seen
part of
that.
the withdrawal. Yeah. So clozapine's a wonderful option.
Yeah. So we are just after 1 o'clock. So thank you all very much. Thank you, Dr. Wilson. Appreciate your time. Look forward to seeing your work in the published literature more and more. And thanks to all of you for your attention and happy Thanksgiving.
Thank you.
Thank you.